Good morning, everybody. Can I have my slides, please? First of all, thanks Professor Nagaraj Desai and Dr. Prabhakar for inviting me. It's been a permanent fixture and I'm really happy to be here. Myocardial viability is an important topic, can be very technical, pathology, imaging, decision making, everything can be very confusing. I will try to make it brief and simple so that we should know what to look for, what tests to do, and whether we should do this test at all in our day-to-day decision making process. Myocardium, which is not functioning well but has a potential to recover with some intervention like medical treatment or revascularization, is called as viable myocardium. Usually we apply this term to ischemic LV dysfunction cases. So it is typically seen in multiple blocks where the heart muscle down-regulates both its metabolism and contractility. But it can also be seen in other conditions like acute coronary syndrome, where there is stunning after resuscitation, cardioversion, etc. But typically we generally talk about myocardial viability in the realm of ischemic cardiomyopathy. It's an important issue because we know that heart failure with reduced ejection fraction has a high mortality. Out of that, if the myocardium is viable and if the patient is treated well, the mortality reduces. So therefore, it's important for us to know whether ischemic ventricle has myocardial viability. We talk about two different types of viable myocardium. One is hibernating myocardium, where there is chronic dysfunction of the LV muscle because reduced flow. And this often recovers after revascularization. Then there is something called a stunned myocardium. After acute coronary syndrome, LV seems down, but over a period of time, it can recover even without revascularization. I'll show you a schema. There is this entity of myocardial ischemia, and if there is an acute coronary syndrome, onto your left you see if there is timely reperfusion, myocardial stunning can still be seen, but eventually the contractile force function can recover if the perfusion is in time. But if the occlusion of the coronary artery is severe and it is prolonged, then it can lead to myocardial necrosis. On the other hand, if there is chronic low blood flow due to multiple blockages, hibernating myocardium is where the myocardium reduces function, but when the myocardium is revascularized, it can lead to recovery of contractile function. How do we test for myocardial viability? There are three types of tests: morphology-based tests, which are like cardiac MRI and echo; perfusion-based methods, cardiac MRI again, and SPECT; and also the metabolic function of the myocardium can be tested by PET scanning. These three types of tests, the main ones are SPECT, PET, the radionuclide studies, cardiac MRI and dobutamine stress, have their own advantages and disadvantages. The first two being expensive. Dobutamine stress echo is inexpensive, accessible, but one should have a good machine, a good echocardiographer, and good analytical power to assess this. It's a little technically demanding test. Now, coming to FDG PET, this 18F FDG is a radio tracer. It's a glucose analog which has been tagged with fluorine. It enters into the cell, and during the glycolysis it gets trapped in the mitochondria, and there is no further metabolism. We know that when there is hibernating myocardium, the glucose transporter receptors on the surface of the myocyte is overexpressed, and therefore hibernating myocardium accumulates a lot of this FDG. So in this test, what is first done is the perfusion of the myocardium is first tested using rubidium-82 or 13N ammonia. I'll show a picture so that this becomes more clear. After about some time, insulin and glucose are infused. and then FDG is injected. In a hibernating or a normal myocardium, this tracer is taken up normally because the myocardial cells are alive. And in an infarcted myocardium, there is no uptake. So here is a picture. On the left panel, we see that the anterior and septal area has less perfusion. That is the ammonia scan, which shows perfusion. There is a perfusion defect. However, when FDG injected, we see that even that area lights up. So that is normal uptake. That means those cells are alive. In spite of the fact that there is no perfusion here, the cells are alive. So this kind of perfusion and uptake mismatch in FDG PET tells us that this is viable myocardium. So FDG PET is one of the best tests. It is said to be the gold standard for testing myocardial viability. The other radionuclide test which we do is thallium-201 SPECT. Now here what happens is, it's a potassium analog. So if a cell membrane is intact, the sodium-potassium pump is functioning, therefore the cell takes up the potassium. And initially the potassium uptake is because of perfusion, and later redistribution happens because of gradient between the cell and the blood pool. Now, if the cell is ischemic, if the myocardium is ischemic, the washout of the thallium from the myocardial cell is slow. So what we see is this. On the top, the big arrows show that the mid, anterior and lateral wall have low perfusion. The lowest panel, after 24 hours, we see that the redistribution happens. So that means though the anterior and lateral portion of the myocardium here, the LV is viable. On the other hand, the inferior wall, the lower arrows which look up, there is a fixed defect on top and there is a fixed defect on the bottom, which means these are non-viable cells. So SPECT, thallium SPECT can also tell us viability. Then there is a classic test called dobutamine stress echo. When we infuse low dose dobutamine, there is an improvement in contractility, and when we give high dose dobutamine, because it induces ischemia, the contractility can become less. So this is called as a biphasic response. A biphasic response is classic for viable myocardium. So we can, using dobutamine stress echo, identify viable and non-viable myocardium. So I've discussed about 3 tests: PET, SPECT and dobutamine stress echo. These are usually the tests performed to identify myocardial viability. Cardiac MRI is now coming up as a very important tool for many cardiac diseases. If we have an end-diastolic wall thickness of less than 6 millimeters, some people talk about 5.5 millimeters, then it's almost always non-viable. We can also perform stress MRI. Low-dose dobutamine can be infused, and then MRI can be taken before after. If there is 2 mm and more thickening of the myocardium, that means the myocardium is viable. Gadolinium is a contrast which is injected and it gets accumulated in extracellular space. If the cells are dead, there is more extracellular matrix, so gadolinium enhancement happens in scar tissue. So we can look at, for example, these pictures, the top 2 pictures, they show before and after gadolinium. There is no white areas in that LV. On the other hand, in the bottom, you see that there is no white area, but on the right side, we can see the scar is enhanced by gadolinium. So that says that the lower panel, this is non-viable myocardium, and the upper panel shows viable myocardium. So CMR is also an excellent test to assess viability. Now, when it comes to viable myocardium, what is the accepted paradigm? We feel that there is some myocardium which is not functioning well. We revascularize. And when we do that, if the myocardium is viable, the cells will regenerate. If the myocardium is non-viable, the cells won't regenerate. This is the accepted paradigm, which is why we test viable myocardium before any revascularization procedure. But what is the basis of this kind of accepted paradigm is very early studies, 80s, 90s especially, they showed that there is a correlation between viability and recovery of LV function following revascularization. There were small trials, and there were many meta-analyses. One of them I have projected here, and they showed that presence of myocardial viability predicts benefit following revascularization. So viability testing became norm before revascularization in ischemic cardiomyopathy. However, what we now know is most of the studies included in these meta-analyses were retrospective, observational. Myocardial viability definition was not standard across all these studies, and then there was no guideline-directed medical therapy at the time. It was just about talking about revascularization. A lot of things have changed, and this accepted paradigm has been now called into question. Does myocardial viability stand the test of time pre-revascularization for ischemic cardiomyopathy is a question asked. So there are some important trials which looked at, randomized control trials which looked at viability and revascularization outcome. There are 3 trials which I will quickly discuss. This is a trial, PARR2 trial, where FDG PET was done, and in this trial the author conclusion is the study did not demonstrate a significant reduction in cardiac events in patients with LV dysfunction and suspected coronary disease for FDG PET assisted management versus standard care. So they did not see that whether after PET, whether viability was there or not, the outcomes were similar. Critics question this study because it is a small study. Nearly 25% of patients did not adhere to the PET scan recommendation. That means if PET said you have to have surgery, 25% of them did not have. Again, when PET said you don't have surgery, the 25% of patients underwent revascularization. So because of that, it's all got contaminated. Therefore, most experts don't accept this study. However, a landmark trial called STITCH trial, which compared bypass surgery with optimum medical management versus OMT alone, this study is very important because they pre-specified 600 odd patients who underwent either SPECT or DSC to see whether there was viability or not. In this group, the first conclusion that came was, in patients with ischemic LV dysfunction, bypass surgery with OMT was better than bypass surgery alone, OMT alone. However, benefit of revascularization was seen whether the patient had viable myocardium or not by these 2 tests, SPECT and DSC. So therefore, the author conclusion, which I have underlined there, we did not find a significant interaction between myocardial viability status and medical versus surgical treatment. What was seen is, even with whether the patient had viable myocardium or not, even GDMT helped, revascularization helped. So this study calls to question whether myocardial viability testing should be done before we look at revascularization. Elders, very senior cardiologists here will remember that early on, trials like CAS trial, they never looked at myocardial viability. Patient with triple vessel disease, severe LV dysfunction, they went ahead and operated, and they found that surgery is better than medicine. So there was no question of looking for myocardial viability at that time. So which is why these things are being looked at once again. And when it comes to PCI, whether we should look at myocardial viability or not, this is a UK trial, revived BCS2. This studied the difference between PCI and OMT in ischemic cardiomyopathy where PCI is possible. In this, the primary outcome was similar whether the patient underwent PCI or underwent medical treatment. So the conclusion of revived BCIS2 trial was that in case of severe ischemic cardiomyopathy, PCI does not improve outcomes when compared to medical therapy alone. So on the other side, what they did was there was a pre-specified 610 patients who underwent DSC or cardiac MRI for assessing myocardial viability. Again here, there was no association found between the extent of viable myocardium and the outcome. So the author conclusion I have underlined here again, the study found that viability testing does not identify patients with ischemic cardiomyopathy who can benefit from PCI. So these 3 trials now call to question whether we should actually be doing viability testing in patients with severe LV dysfunction and coronary artery disease before subjecting them for revascularization. However, I don't think a final word has been said, because intuitively it looks like patients with viable myocardium, when they are revascularized, obviously should do better. So therefore, both ESC and ACCHA have kind of hedged the recommendations. In 2018 ESC CTS guidelines, they say the lack of correlation between myocardial viability and benefit from revascularization indicates that this strategy should not be the only test when selecting optimal therapy. I think we have to look at other patient parameters also, whether there is underlying valvular disease, what is the extent of coronary artery disease, is it amenable to revascularization. I think these also should be looked at. Merely looking at viability, and like it happens sometimes in our practice, we deny revascularization for some people. In fact, I think one of the commonest reason why viability testing is done is when the patient has severe LV dysfunction and the patient is high risk. We look for viability, and if lot of non-viability is seen, if lot of scars are seen, we reject the patient from surgery. So whether we should be doing that is what the question here is. So ESC says that this is a class 2B indication, viability testing, so it's not absolutely necessary. AIHA goes even further. It says the role of myocardial viability testing in guiding revascularization decision remains uncertain. So they call for more randomized controlled trials to see whether we should actually be doing viability testing in ischemic cardiomyopathy before subjecting the patient to revascularization. So viability is an important prognostic factor. If myocardium is viable before revascularization, outcome is good. Viable before GDMT, outcomes are good. That is known. Important tests are DSC, radionuclide studies, and cardiac MRI. There are conflicting views on viability testing, whether we should do this before or after, and whether it will actually predict outcomes. Both guideline-directed medical treatment and revascularization improves LV function in patients with significant myocardial contractile reserve. So in that sense, to prognosticate, maybe not to choose for surgery, but to prognosticate a patient's outcome, it may be worthwhile doing myocardial viability studies. Thank you very much.
Thank you, Dr. Venkatesh.